I welcome everyone to the HFSA Heart Failure Patient and Caregiver webinar on hypertrophic cardiomyopathy, a change of heart. I'm Andrea Gavin. I'm a Heart Failure Council certification member, as well as a dilated cardiomyopathy patient. First of all, I'd like to thank and recognize our sponsors, Bristol Myers Squibb and Cytokinetics. So thanks to them for letting us have this webinar tonight. Today, a heart failure specialist will discuss the clinical aspects of hypertrophic cardiomyopathy, known as HCM, followed by a patient who's also a provider speaking about their journey with HCM. We'll take questions and answers both segments. Just so you all know, you will be receiving an evaluation for this event, and we really would appreciate your feedback. So there's a QR code that will happen during the presentation, and you will also receive an email after the webinar for your feedback. So let's get started. Our first speaker is Dr. Andreas Carmona from the Cleveland Clinic. He is a cardiologist in the section of heart failure and cardiac transplantation and amyloidosis center at the Cleveland Clinic. Welcome, Andreas.
Thank you for the invitation. It's a pleasure to be here speaking about hypertrophic cardiomyopathy. And my goal is to try to make it as simple and to the point as I can to try to get the message out on what this is, what to expect, and what you can do. We'll get started. So I don't have any disclosures. The objectives today is to know what is hypertrophic cardiomyopathy, how common and what are the causes, what are the symptoms that you can see, how can we diagnose it, what are the treatment strategies that are currently available, what are the future directions and some of the clinical trials that are available out there in the country, and what are the resources and support groups available for our hypertrophic cardiomyopathy patients. So starting off with the definition, we know now that it's a problem that involves solely the heart. It's characterized predominantly by thickening of the heart, what we call LVH, or the acronym is for left ventricular hypertrophy, when that is in the absence of another cardiac, systemic, or metabolic problem that is capable of causing the thickening of the heart that's evident in a given patient, and for which a genetic reason has been identified or still remains unresolved because the genetic maybe mutation has not been associated with hypertrophic cardiomyopathy yet. And a clinical diagnosis of HCM in adult patients can therefore be established usually by using different imaging techniques. So how common is this? It's about 1 in 500 patients, so 0.2%. This is based on some studies that were based on echocardiograms, ultrasounds of the heart. But now we know by using other imaging techniques like cardiac MRI, getting a really good family history with genetic testing, that actually might be more common than 1 in 500. It might be more 1 in 200 patients. This is in the United States, around 750,000 patients that we can see, and it really is a entity or a disease that it has equal opportunity because it doesn't distinguish between gender, age, or any ethnic factors. So what causes it? It's a genetic variant. There's about 8 genes associated with hypertrophic cardiomyopathy. That's usually 30 to 60% of the patients, and the two most common are the MYH7, and the other one is the myosin binding protein C3, which is that long acronym you see there. And there's other about 40% without genetic variants that also can have an affected family member. It's important to know that there's a lot of mimickers, some entities, some diseases that are very similar to hypertrophic cardiomyopathy. So it's always important to look at those to make sure that that's not the reason that the heart is thickened, that there's that LVH, like athlete's heart, high blood pressure, valve problems, conditions that are more specific like Fabry's disease, amyloid disease, sarcoid, or some other genetic problems that can cause cardiomyopathies. And the importance of all of this is that the treatment is very different from some of these conditions, and it's important to get it right. The types of hypertrophic cardiomyopathy we can divide them in the ones that have obstructive hypertrophic cardiomyopathy and non-obstructive. And what does obstructive, non-obstructive mean? It basically goes down to where that arrow is, that area which is called the left ventricular outflow tract, or LVOT. And if there's an obstruction because the muscle is too thick and it blocks it, it's considered obstructive. And if it's not blocking it, then we consider it non-obstructive. And that can come in different flavors. The non-obstructives can have a different type of way that the septum looks, how you can see on the left side. The obstructives can be also not only close to that LVOT, but it can be also in the middle of the chamber, sometimes close to some of the valves that we have, like the aortic valve. They can be in the middle of the chamber. And then we have other ones that actually we consider latent because they're not necessarily there with just a resting image that we get, but sometimes with provocation. The symptoms that we can see, some patients actually present an asymptomatic, but others can have decrease in overall fitness, functional capacity. They can have chest pain, shortness of breath, palpitations, passing out spells, usually with effort. And that's because of all of these on the right side, those circles, different reasons like rhythm issues, heart attacks, autonomic dysfunction, which is basically when the blood pressure just changes very rapidly and can cause these symptoms. How to make the diagnosis? The first thing is to suspect it. And so a physical exam, a good physical exam where you can appreciate a murmur, some swelling, abnormal lung sounds, abnormal rhythms. Getting a good family history is very important. And then basic cardiac testing like an electrocardiogram or EKG, Holter monitors. And then we can do stress testing, echocardiograms on the right bottom, and then cardiac MRIs, which have changed a lot how we look at this and distinguish and stratify the diagnosis. It's very important I bring up like this family tree that you can appreciate here, because getting a good family history is extremely important. And you look at from the top, the A column, where this patient, and that is the one that in the black square, that was the first patient. And so that puts the other ones with the arrows at risk. So we get a family history and we see that the side of the mom, which is that circle, that's 2-4, we see that there's a lot of patients there that could be at risk, and another one that we identified that had hypertrophic cardiomyopathy. And so if we further stratify that, and then ultimately in D, where we do genetic testing, we can see that all these patients are potentially at risk or are carriers or not carriers. And so that's why it's extremely important to understand if this is something that you have or not. And then other thing that's important is in the father's side, there's nothing to worry about because they actually don't have the gene. In terms of treatment strategies, this is a little small, but the most important thing that I wanted to talk here is that the first thing we do, the first line, is medicines, usually the beta blockers and the calcium channel blockers, and I'll mention some later, and that just basically slows down the heart and decreases that potential obstruction that can happen. When that doesn't work, then we can keep escalating to different medicines like myosin inhibitors, which are included in the guidelines this time, and then other medications. And then we can also proceed with surgical things or minimally invasive procedures like alcohol septal ablation. When we talk about what to do when patients are symptomatic, we can also stratify them according to their ejection fraction. Is their ejection fraction less than 50%, more than 50%? If they're less than 50%, we usually treat them like any heart failure patient, but having in mind that they do have the hypertrophic cardiomyopathy, obstructive or non-obstructive, to be able to also stratify if they need protection against, for example, sudden cardiac death and need a defibrillator. And we can stratify that by evaluating case by case. And in some patients, when things are not getting better and we've tried medicines or treated some arrhythmias, we always have to keep in the back of our mind when everything is done in terms of devices, medicines, well, is this somebody who we need to consider for transplantation? So that's why it's always very important to be at a place where they understand what is happening in the evolution of the disease, so they can address the problem as it comes and as it gets worse. So what medicines can you use? You can use beta blockers like metoprolol, bisoprolol, carvedilol. You can use calcium channel blockers like diltiazem and verapamil. Those are the ones that we recommend. And then we can use now myosin inhibitors like mavacamten and other medications like disopyramide. In terms of procedures, we have the alcohol septal ablation and the septal myectomy. That's a surgical procedure. The other one is minimally invasive. Some of the future directions, there's a lot of research still happening with mavacamten and patients that have non-obstructive hypertrophic cardiomyopathy. There's another myosin inhibitor that is also promising and that is being studied in symptomatic obstructive hypertrophic and non-obstructive hypertrophic cardiomyopathy. And then there's some other ones that are more gene-based and targeted that are also coming up as well. It's really important to know that you're not alone in this problem, and there's a lot of resources and support groups available where you can connect with patients and ask a lot of experts and get a lot of information in terms of reading material, podcasts. We have the HFSA Patient Hub where you can get a lot of information. You can go to the Hypertrophic Cardiomyopathy Association where there's a lot of information there as well. And then also the AHA has really good health topics addressing hypertrophic cardiomyopathy. Well, thank you very much. And I'll pass it along to Andrea and then Ilton.
Thank you, Andreas. Just a reminder to please post your questions in the questions section, and after our second presenter, we will go back and ask both presenters questions. Next, we have Dr. Ilton Cubero, who is an advanced heart failure and transplant cardiologist working at Johns Hopkins Community Physicians in Bethesda, Maryland. Additionally, Dr. Cubero is a provider living with HCM. Over to you, Ilton.
All right. Thank you guys for having me. So I figured I would just share a little bit of my story, and I made some notes to make sure I sort of stay on track here. But to start off with, I wanted to start by sharing how I came to find out that I had HCM. Ironically, it was in medical school. I have to say that I was fairly inactive prior to medical school. And I was at a place where people were just very outdoorsy, very active. So I kind of got interested in that. And it wasn't until I started trying to do those things, for example, hiking or going to the gym, that I noticed that I really couldn't keep up. I mean, I remember very clearly going on a hike that was during our med school orientation, and just going up a hill was a real struggle. I felt very short of breath, felt very winded. And then at the same time, I'm 21, 22 years old, looking around at my colleagues and everybody looked comfortable and fine. I just kind of assumed it was that I was out of shape at that point. And I just kind of kept going along. I remember at one point I went to a doctor. I was wondering if I had asthma. My mom had asthma, so I thought maybe I had asthma. We tried inhalers, that didn't work. And ironically, it can actually make it worse. So I kind of just chugged along for a while. I didn't really put too much attention to it. After all, I was in med school and very busy. And then it was in one of our classes where we practiced physical exams on each other, where a classmate and friend of mine heard a murmur. And that's kind of what kicked down the process of getting a diagnosis. It actually wasn't for a few months because I was still kind of ignoring it, but eventually I went to a doctor who did the echo and diagnosed me with HCM. For a while, as Andres mentioned, I was on medications. I'll be honest that I didn't notice a huge difference. I felt a little bit better. I felt like I could maybe push myself a little bit more, but I still felt quite limited in my ability to exercise. But I kind of just accepted that as a reality because the other sort of treatment option at that time was open heart surgery. So I kind of went on through medical training, residency, eventually fellowship, kind of chugging along, feeling okay when I'm doing normal things, but was never really able to exercise. And I wanted exercise to be a bigger part of my life. I felt like that was my way to stay healthy for the long run. So eventually I got, I started thinking thinking about other treatment options a little bit more. I actually started getting a little bit more symptomatic. My main symptoms were shortness of breath with exertion, sometimes chest pain. And then the thing that happened on a regular daily basis was actually lightheadedness. I would get very lightheaded, almost felt like I would pass out. Even just standing up from a chair in the middle of the workday would happen several times. And you kind of just adapted and got used to it. But one day I was talking to a mentor of mine who's a cardiologist, and she said, I think you need to have surgery. I think it's time you should go talk to one of the surgeons. So I did that. This was 2021. It all happened relatively quickly. I actually went to Mayo, where there's a lot of expertise, and one of the world's top experts in this particular surgery works. And I had surgery there. That was obviously quite a big deal. The recovery was long. It took me about sort of 2 months to get back to something close to normal. But that was actually quite life-changing. By the 6-month stretch, 6 months post-op, I was running regularly, exercising regularly. About a year afterwards, I had run a 10-mile race, which was a shock to me. I never thought I'd be able to run that kind of distance. I got really encouraged, kept exercising. A couple of years later, I was actually able to complete a marathon, which was, again, a shock. And that's kind of how things have been there. I kind of took that as a huge gift, having that surgery and feeling as well as I do these days. And I keep running, and I'm actually training for another marathon this October. So hopefully I can finish that one as well. So I'll stop there because I think we can allow time for questions.
Great, thank you. So as a reminder, please put any questions in the chat, and we'll start with a question about diagnosis. When newly diagnosed with HCM, what should I ask my doctor about my disease?
I think that's a great question. I'll start, Ilton, and so when you get a first diagnosis of HCM, you should start inquiring of potential medications or potential diagnostic tests that you need to have done, because right now what we do is we usually get the basic things like an electrocardiogram, the EKG, an echocardiogram. At times we have to get Holter monitoring as well, which is something I do routinely to kind of understand if there's any rhythm issues that can put you potentially at higher risk for sudden cardiac death. There's some patients that even though we're putting them on medicines, they need a stress test to stratify that the problem, the obstruction even further. And so the important thing is first, am I on the right treatment? Did I get the most important or the relevant diagnostic test? And I also ultimately, do I need surgery or do I not need surgery? I think those are good questions to start with.
Two questions for you, Ilton, about your treatment. One, what surgery did you have? And do you take any medication?
So I used to take medication. I was on various types of beta blockers at various doses over the years, from I would say 2012 to around 2021. I had the open heart surgery, which is called the septal myectomy. So that's where they go in and basically just slice the piece of muscle that's blocking blood flow from the heart to the rest of the body. And since then, I don't need to be on medication. So I'm currently not on any medication. And I'm basically symptom-free at this point.
Great. Next question is, what is the criteria for this diagnosis? You've done a good job about talking about the symptoms that patients may exhibit. What are the objective diagnostic indications?
So the main thing that we can use is for somebody who has the left ventricular hypertrophy, so meaning the thickness of the heart muscle, the left ventricle in particular. And so Ideally, when we see patients, we try to see what, depending on the sex, what the normal parameters are, which that can be between like 0.8 to 1 millimeter or 1 centimeter of the width or the thickness of the ventricle. And so when we see that starts becoming thicker and thicker and get to the point where it's like 3 centimeters or 2 centimeters, 3 centimeters, and it starts causing issues, that's something that we start noting. Then the other thing is in the obstructive component, then because there's that LVOT obstruction that can happen. Basically, when that obstruction happens, the pressure gradient, meaning there's a big gradient between where the side that's the obstruction, one side and the other one, and that basically does not let that obstruction doesn't let the blood flow go, and that the more that gradient is, the worse that obstruction can be, and we see that patients are usually more symptomatic when they have that obstruction. And so usually the main things that we use is that LVH, which is the thickness of the heart, and the more that thickness is, then the worse we see usually in terms of symptoms.
And then I would just add to that, which was a really excellent answer, that part of the diagnosis of HCM is excluding all of the other things that Andreas mentioned in his presentation, because there are what we call mimickers. So you have to kind of exclude those things before you kind of go down the pathway of treatment for HCM.
Right. Yeah. That's very, very important because the treatment, like I mentioned before, and like Ilton is saying, they're very different. So you really want to hone in that this is the right diagnosis to be able to treat it appropriately and correctly.
Thanks. And then a question on medication. What is the best medication for quality of life with heart failure?
Ilton, you want to take this one?
Yeah, so I would say it depends. Different medications have different effects on different patients. So there's always some component of trial and error with your doctor. What might work for one patient may not work for another. The options have expanded. So now there's the beta blockers, the calcium channel blockers. There's an older medication called disopyramide. I've seen all of these work for different people. And then now the new kid on the block is called mavacamten, which is medication specifically for HCM, and that can also work for people. So it just depends on the individual. And I think an HCM doctor can help you walk through that and guide you through it.
Yeah, I think it's really important to, usually we try to go with like the first line of therapy, which is the beta blockers and the calcium channel blockers. And then if those don't work, then we start jumping to the other medications, but it's a matter of finding the right combination. And like Dr. Cubero, Ilton is saying that mavacamten is definitely the new kid on the block, but it takes a process to be able to prescribe it, and then you need routine echocardiograms that you need to follow, and so it's really important to tailor the medicines that you're using to the patient that you have in front of you, and so that's what you should be asking your doctor.
I see a couple questions about surgery. Does the muscle return after a myomectomy?
I can take that. So it shouldn't. So this condition really, it sort of settles in adulthood. So there may be some growth in younger kids or in childhood sometimes. But once you're in adulthood, that really should sort of be at its peak. And it shouldn't grow or come back. The only situations I've heard where there's some concern of that is, one, if somebody is really into heavy weightlifting can increase the thickness of the heart. That's one example, and I mean you'd have to be pretty intense about it. And the other is if it's perhaps if it was done at a center where perhaps they do less of these, and maybe just not enough muscle was taken off to begin with. So it's not really growing back, just not not a complete surgery, let's say.
Yeah, and then a lot of patients also can develop common things like hypertension. And so
Yeah.
hypertension can also, like high blood pressure can also make that thickness come back a bit, but it should not necessarily go back to what it was before, like Ilton is saying.
And after surgery, is there any prophylactic medicine for the future in case of symptoms?
So
So
not
I can,
necessarily.
or you,
Yeah, not necessarily. So you can have some patients on some of these medications after the surgery, but like Ilton is saying, like he's not on any medications that, necessarily at the moment. So it's not like other conditions where you can do something prophylactically so it doesn't come back. I don't think we're yet at that level, and necessarily if you have things like surgery, it should not be coming back.
So what if a patient is unable to do surgery? What main medicines should they use?
What was the last part, sorry? They can't do surgery?
What main medication should they use? Yeah.
And so if they can't do surgery, there's minimally invasive procedures that could potentially be done, like alcohol septal ablation. That is if that is needed. But we've seen now with the new kid on the block with the mavacamten that that's something that can potentially be used and has been really helpful. And so that is something that fortunately was added in the guidelines this year that was recently published. And so it is a new line of therapy that can be done in those non-surgical patients to see if there's a benefit. And we do see in the clinical practice that a lot of patients respond really well to mavacamten. Ilton, the same experience in your case?
yeah, I would say so.
We have a patient-specific question. I have ATTR-CM and heart thickening, and I've been symptom-free, but I'm now experiencing limited shortness of breath from time to time on exertion. Taking statin and Vitamex. Will these meds help with heart thickening, or do I need something more?
So it's a little different pathophysiology when you're talking about amyloid caused by ATTR, either hereditary or wild type. And so Vindamax, basically what it does, it prevents the progression of the disease. We published here at Cleveland Clinic a series where actually a lot of patients that have hypertrophic cardiomyopathy that came through and ended up having myectomy, some of those patients actually had ATTR cardiomyopathy, which is really interesting because these patients with ATTR cardiomyopathy can also present not only with thickness all over the heart or uniformly over the heart, but also in a similar way that hypertrophic cardiomyopathy presents. That's why we call that it can be like a mimicker of other conditions, because things like amyloidosis can be very similar to how hypertrophic cardiomyopathy, non-obstructive or even obstructive, can present itself. And so I think it's important to look at that distinction. And there's now other clinical trials that have been started with monoclonal antibodies and other medications that potentially will help some patients with ATTR cardiomyopathy.
Next question, if one has HCM, does that mean he or she is in heart failure?
So no. So heart failure is a syndrome. So heart failure is somebody that has a lot of symptoms like shortness of breath, they can have swelling in the legs, they can have rapid weight gain. And so not everybody that has a cardiomyopathy necessarily is in heart failure. And so that's an important distinguish. Something to distinguish very off the bat. I try to tell patients when I see them in a clinic, well, you have a cardiomyopathy, it's a problem in the muscle, but at the moment, fortunately, you don't have heart failure. And so what we try to do is, depending on what type of cardiomyopathy is we try to keep patients from going into heart failure. And then we do this in different ways. Medications usually help a lot.
Great. So what are you looking for as successful with various drugs? Of course, there are side effects that aren't tolerable, but would you try something else? what changes in an EKG would make a drug's choice successful? So I guess what are the metrics of a drug working?
So it's mainly symptom driven. And so usually what we not necessarily look for things on particularly in the EKG. What we usually see in the EKG is that the patient has a really high voltage because of the thickness in the heart. And so when we start using medications and then we start going up on doses pretty rapidly, especially the first line, the beta blockers and the calcium channel blockers, our goal is to help with those symptoms that the patient is having, like the shortness of breath, the chest pain. If that doesn't help, then we go to the second line, which involves, the new kid on the block, the mavacamten, the disopyramide, or considering a surgical opinion. And so that's mainly what that I usually like guide my practices symptom improvement. I don't know if Ilton has a comment.
Yeah, I mean, it's all about symptom management and quality of life, which can be different for different people. If somebody just wants to be able to go about their daily life, go to the grocery store, pick up their kids, play with their kids, or whatever it may be, then those goals may be different from someone who wants to be able to exercise and that kind of thing. So it should be pretty tailored to the specific circumstances of that patient.
So given the success of your surgery, Ilton, should everyone get this procedure?
No, I think it depends. It's so patient specific. It's such an individual decision. I was pretty symptomatic. I had as Andres was describing, I had a pretty high gradient, so a pretty high degree of blockage of blood flow from my heart to my body. And medications weren't really reducing it, and I wasn't really feeling better from them. So I think in my case, it was the way I thought about it. It was a risk benefit sort of decision I had to make. Is am I willing to undergo the risk of surgery, which fortunately with the surgeon that I had, his risk of complications is very, very low, and also the fact that I was 31 or something like that, 32 at the time, means that my overall risk was very low. To gain those benefits of trying to have a higher quality of life that I was looking for. So it's very individual. I think it has to be sort of a discussion with you and your cardiologist, probably your spouse also, your friends and family. It's not a small undertaking to have heart surgery.
And we see different patients. Some patients say, let's try all the medicines possible. I don't want to have surgery. And then we see the other side. Some patients is like, I don't want to take medicines. I want to have something that fixes it. And then I'm okay from there and I don't have to take anything. And so we try to do a lot of shared decision making to be able to meet the goals that the patient wants to have.
One patient is asking, I had a septal myectomy and now I went from mild to moderate MR regurgitation. Any advice for this patient?
Do you want to take that, Andres, or do you want me
Or
to?
maybe it's a specific question for their doctor.
You can take it if you want.
Yeah, so I think that's sort of a separate but related condition. Mitral regurgitation can happen at the same time as HCM. Sometimes it can develop for separate reasons. Generally mild to moderate, it's not a huge change in terms of how it affects the heart, but certainly can affect people differently. So I think it's generally speaking something to watch with your doctor, something to keep your doctor posted about if you're having any change in symptoms. And there are different treatment options should that ever become severe that have been developed over the last decade or so. So I think it depends on your circumstances, degree of symptoms or no symptoms, and how it progresses over time. So I think it'll just be most likely something you have to watch closely with your doctor and make sure you alert them if you're developing symptoms.
Great.
And a non-surgical question is, can heavy weightlifting lead to late onset HCM in adults?
Yeah, you can take that also. You
Yeah,
went.
so HCM is it's best thought of as a genetic condition. So it's a condition that you either have or you don't have. With that said, there's a little caveat, which is that a substantial portion of patients, and the number that pops into my head is 40 to 50%, will not have any genetic mutation that we have identified. So weightlifting on its own should not lead you to develop HCM. It's a very specific condition with sort of a very specific disease course and specific findings. Weightlifting, if you're lifting really extremely heavy weights for a very long time, that can thicken the heart, it can enlarge the heart, but that's an entirely different process. And generally speaking, that can improve with stopping the weightlifting. And then there's the overlap. If you have HCM, could that make it worse? Potentially. I mean, I think there's some reasonable physiological basis to think that it could potentially worsen it.
Yeah.
And what should a patient look for in terms of heart muscle thickening?
So in terms of the heart muscle thickening, like I mentioned before, it can vary. And so it doesn't necessarily have to go to like that 3 centimeter mark that I was mentioning. Patients that can have much less of thickening of the heart, but because that obstruction is close to that left ventricular outflow tract during, for example, some episodes that where they're doing some exertion that can cause the obstruction. And so it's just one of the parameters that we use to kind of stratify patients and watch them. But it doesn't necessarily have to be a certain like specific cutoff where somebody's not going to have symptoms and another person is going to have symptoms. It's just some guidelines that we have in terms of maybe offering surgery or doing more vigilance in terms of imaging that we're gonna do for surveillance.
And as a quick example of that, after I was diagnosed, eventually my family all had genetic testing and echocardiograms, and it turns out that my middle sister also has HCM, and she actually has about the same level of thickness as I do, which was around 2.2 centimeters or so. However, she has no obstruction. So even though she's my sister, even though we have the same mutation, even though we have the same level of thickness, she actually doesn't have the obstruction component of it. So that I'm just saying that to highlight that these things can vary greatly individual to individual, even within the same family.
Let's see, which procedure has more scarring, alcohol septal ablation or surgical myomectomy?
I think they can both have scarring. I think that the surgery is something that's more controlled, where they go and basically take a part of the muscle. When they do the alcohol septal ablation, it's kind of like a controlled heart attack because when they inject the alcohol, that's kind of what they're producing, and sometimes that can be unpredictable. And so that's why if we have the option, if the patient is a surgical candidate, that's what usually we prefer.
And I would piggyback off that just to say that when you're trying to decide about what's best for you, one of the factors that is sort of like an unfortunate reality is that it's important to try to get a sense of what the expertise is that is available to you. So if you have a surgeon that does, 200 of these a year, then that person is very qualified and they're going to do a really good job. If you have a surgeon that does 5 of these a year, then that person may not have the same level of experience, may not be able to get the same level of results. And same for the alcohol septal ablation. If you have somebody that does this all the time, routinely, has done hundreds of cases, then that person is going to be able to get a better result than someone who's done a few of these. And unfortunately, the people that are trained to do these things are not everywhere in ample numbers. So it's good to ask about what the level of expertise is and what might be better offered at your particular location or community.
And one question is, what happens to a patient who participated in a clinical trial with mavacamten, for example, and improved, but due to lack of resources, they're no longer able to get the drug? Will they get worse again?
That's a good question. I don't know if we have a specific answer for that. So usually there's a lot of resources available out there in terms of patient assistance programs, especially when somebody's been enrolled in a trial that you could potentially try to seek. But once you have the myosin inhibitor and you have the benefit of the myosin inhibitor, if you take that away, there is potential that the symptoms can get worse. And that's what I've seen in a couple of patients that unfortunately have gone through that. Don't know if Ilton, you've experienced the same or have a different experience.
No, I can't say that I would have a ton of experience with that specific situation. I would say that I would imagine that it would go back to how you were feeling before. And you maybe, Andres, you can comment on this a little bit more. I wouldn't necessarily expect it to get worse from how it started, but it would definitely be worse from how you felt on the medication.
And that's what I've seen in the couple of patients that it's happened. Yeah.
Well, we have a couple more questions if you don't mind going a couple minutes over. But I guess the question is, what advice would you give to newly diagnosed patients?
You cut it and what?
Oh, sorry. What advice would you each give to a newly diagnosed patient?
Ilton, go ahead. I think I kind of said in the beginning, let's see what you say.
Yeah, I think, and this kind of gets us at greater problems in our healthcare system in our country, but if to the best of your ability, try to go somewhere where they have an HCM specialist. That's just the best way to make sure that you're being well taken care of. General cardiologists may have some experience with it, but they just don't see it as much to be as qualified as somebody who sees this all the time on a daily basis. Two, and I really want to make this point because I think this is really important. One thing to consider is that, as Andreas pointed out during his presentation, it's a genetic condition. So that means that your siblings, parents, and then your own kids could have this condition. So make sure that you ask about genetic testing. And related to that, if you're somebody who is of age and of reproductive age and you want to have kids, you should know that there are ways to be able to avoid passing this down to your kids. It's through a process called pre-implantation genetic screening. And what it basically works like IVF, where an embryo is created from the sperm and the egg from mother and father. That embryo is then tested for the mutation that you have, and you can selectively pick the embryos that don't have the mutation so that you don't pass it down to your children. And I mention that because I think as sort of a patient, even though I knew about it because I was in medical school and I was a doctor eventually, it was not something that was routinely brought up. And it was something that I made sure to seek out because I wanted to make sure that my future kids didn't deal with this as well.
That's a great
I'll ask a question I think hasn't been asked that I think is important because I actually get often asked about exercise, which I know the current guidelines have changed and now they're recommending exercise. So I'll ask you, Ilton, what are the new recommendations in terms of exercise that are currently out there? Because I know there's a lot of maybe misconception of what activity level a patient can do.
Yeah, so it used to be, even, and I say it used to be, but it was literally when I was diagnosed just 10 years ago, that that you basically were told you couldn't really do any vigorous exercise, and you were limited to milder and moderate forms of exertion, such as maybe jogging, maybe like golf. Ridiculous things were on the guidelines, like sailing, insane things that like don't apply to most people. And I didn't play golf, I didn't sail. I just wanted to run. And so there was a lot of limitations and a lot of sort of fear put into patients. And then there was a study that was published just a couple of years ago that showed that people with HCM can do all sorts of exercise. They can push themselves, they can do vigorous exercise. It basically will come down to that individual's ability and comfort doing it. Not everyone will be able to do it depending on their specific degree of HCM. But to those that can, it's fine to do it. It doesn't lead to a higher risk of death or anything like that, which was sort of the great fear. And related to that, the other point I want to make, because this can all be kind of a scary diagnosis, is that you should expect that, especially if you're under the care of a doctor with experience, to live a totally long and healthy life. And you will probably die of something else like cancer or whatever else. So it's important to stay active and do the normal things that we know to do to keep ourselves healthy, eat healthy, exercise, go to your doctor, get your cholesterol check, all those other things. Make sure that those things aren't ignored, because this diagnosis is by no means a death sentence.
That's actually really important because it's a big change in these guidelines. It's very clear that you can do exercise. So it's important to know.
Maybe, I don't know if you can identify the name of the study, or maybe we can share it in the resource of the call. Someone's asking about the name of the study for reference.
Yeah, it was Live HCM. If you Google Live HCM, and it was published in the Journal of the American Medical Association, and it was either 2022 or 2023, something like that.
Thank you. Well, as we wrap up, any closing comments from either of the speakers?
So I think, like Ilton mentioned, it's important when you get this diagnosis to seek the expertise of one of the HCM certified centers, where you know that there's going to be somebody that is an expert in the area, especially if you've been treated by a general cardiologist and your symptoms are not improving. And also, if you need a surgical option, I think it's important to go to a place, if possible, where they have the expertise and their volume is high, because usually their outcomes are much better as well. And then the other thing is, also piggybacking on what Ilton was saying, is you get the diagnosis. This is a genetic diagnosis, so it's important to consider genetic testing and also talking to your family members, because it's not only like your children or your parents. If you look at that tree that I showed of a family, just by digging and digging, they were able to pretty much find out that a lot of people, and not necessarily that their direct family, were at risk. And so giving them that knowledge and empowering them with that knowledge is important, because then they can decide if they're going to seek attention or investigate or not. So I think those two things are very, very important.
Ilton, any closing thoughts?
I would just emphasize that first, getting any sort of diagnosis is scary, but really the large majority of HCM patients will live a normal lifespan. Obviously, no one wants to live with symptoms. It can decrease your quality of life. So that's why going to a center that has expertise in it is important. So I would second that. And the last thing I would say is, don't neglect the rest of your health and the rest of your body to focus just on this. Make sure you're doing all of the things that we should all be doing at all times. Again, the eating healthy, making sure your blood pressure is normal, making sure you don't have diabetes, and if you do, having that controlled, making sure your cholesterol's checked and controlled, all of those other things that we all have to do. Make sure to not neglect that, because that's much more likely to cause a bad outcome in the future than HCM.
Thank you again. The recording of this will be sent out along with a survey to please share your feedback. Here, I'll actually bring you to the next slide. If you can go directly to the survey now by doing that QR code. And otherwise, thank you everyone so much for joining us tonight. Thank you to both of our speakers, Dr. Carmona and Dr. Cubero, and thanks for joining us. Have a great night.
Imagine what we can do when we do it together. A team of hundreds working as one for more than 25 years, testing the limits of science, pushing the boundaries, making the unknown, well, known. We analyze, scrutinize, and challenge the status quo of muscle biology-directed therapies. Imagine a company driven by a shared mission, by an unwavering commitment to patients. This is science fueled by heart. This loyalty to our vision, perseverance, and endurance comes from knowing that with every step forward, a better tomorrow may be possible for patients. Their fight is our fight. Their success is our success. Patients are at the root of everything we do as we work to change the future of debilitating diseases impacting muscle function. And we're humbled by the task at hand. Imagine the frontier of a new dawn with potential muscle-directed medicines bringing hope for a brighter future. But we don't have to imagine any of this, because this is the reality we're creating together today.